Welcome to Grand Rounds. Today we're excited to welcome Dr. Marshall Chin from the University of Chicago. Dr. Chin is a general internist with extensive experience working to improve the care of vulnerable patients with chronic disease. His education, he went to undergrad at Harvard University where he was magna cum laude. His MD was obtained from UCSF, as well as an MPH from Harvard School of Public Health. His residency and chief residency migrated back to Boston and received those from Brigham and Women's Hospital and stayed on at Harvard as a clinical medicine fellow, followed by a health services research fellow. For a faculty position, he migrated to the Midwest and has been at Chicago ever since. At Pritzker, he is now a professor of healthcare ethics in the Department of Medicine, associate chief and director of research, and director of Finding Answers, Disparities of Research for Change. He's a very active researcher and has over 150 peer-reviewed publications, focusing mostly on healthcare disparities and medical ethics, with specific areas of interest surrounding healthcare outcomes and diabetes. He has a specific passion for teaching and mentoring and works actively with many medical students in the clinical setting as well as residents and other fellows. He has numerous honors and awards and committee involvement. He serves as numerous directorship roles for the Center of Clinical Medical Ethics, Excellence in Geriatrics, Center for Diabetes Translational Research, and has also serves as the Robert Wood Johnson Foundation Director of Finding Answers, Health Disparities Research for Change, and Reducing Healthcare Disparities through Payment and Delivery Reform. And he's here today to talk to us about how to achieve health equity. Join me in welcoming Dr.
Well, thanks very much, Lindsay. So I applied for residency here at UW in the primary care program. I applied for fellowship, and I applied for a job at University of Washington over 20 years ago. So I know very well the University of Washington and what a great program it is, both the department as well as the training programs. And last night, it was a wonderful dinner where I had a chance to meet your terrific chiefs as well as Dr. Bremner. And they updated me on the department and the program, and so it really is a great honor to be able to speak with you today. So here are my disclosures. The closest to a for-profit is the Merck Foundation, which is a nonprofit foundation funded by Merck Company. So I have an ambitious agenda for us over the next 50 minutes or so. I'm going to be presenting a roadmap for reducing disparities in healthcare from the perspective of what I think are most of the people in this audience, which are clinicians and folks working in healthcare organizations. It's going to be a comprehensive look because I think that for us to really make progress in terms of reducing equity, we need to have a comprehensive look. I'll then go macro and talk about a population health effort on the south side of Chicago where we're trying to reduce diabetes disparities. I'll then go micro to the individual clinician-patient encounter and explain some communication and organizational context models for improving shared decision-making between clinicians and the LGBTQ racial ethnic minority population. And then I'll end talking a little bit about what you can do to achieve health equity. So pretty ambitious agenda, but I think hopefully one that you'll find stimulating. So Dr. Bremner suggested that I have a couple slides on, just make sure we're all on the same page about what is our health disparities and achieving equity. So this is the NIH definition. It's the difference in the incidence, prevalence, mortality, and burden of disease and other adverse health conditions that exist among specific population groups in the United States. It's a pretty straightforward definition. There's another definition, which is the Institute of Medicine definition, which is a little more complex, but I think helpful for conceptual reasons. So the IOM defines disparities as differences in the quality of health care that are not due to access-related factors or clinical needs, preferences, or the appropriateness of intervention. What does that mean? Well, so here's a schematic that you see here on the vertical axis. You have the quality of health care, so higher is better. This bar, you have a non-minority population, say a white population. Here you have the quality of care for a minority population, say African-American or Latino population. Then you see that there is represented here the difference in the quality of care, which they further subdivide into three different components. One is what they talked about in the definition, clinical appropriateness and the need or patient preferences. So for example, if you're African American and you have an anemia, it may make more sense to order a hemoglobin electrophoresis blood test than if it's a white patient, just because of the increased prevalence of hemoglobin SS in the African American population. Or there's some evidence suggesting that African Americans, on the whole, compared to white populations, tend to prefer a more aggressive style of end-of-life care than white populations. We think a little bit about why that may be so. But that's patient preferences or clinically appropriate care. It's these two boxes here that are, in some ways, healthcare disparities. One is basically the way that we set the healthcare system. Whether unknowingly or through conscious decisions, the way that the system has been set up. At its worst, what some people have referred to as institutional racism. There can be ways that the system is set up in a way that lead to these healthcare disparities. The other more subtle is essentially discrimination or implicit biases, which I think there's relatively little sort of outright discrimination where you say, well, I as a doctor, I'm going to discriminate you because of your skin color or your gender. But a lot of it may be more implicit, the sort of subconscious things. We'll talk a little bit about that later in the talk. I'm also not going to talk a lot about statistics about health disparities. That a lot of times people have talks where they talk about the existing disparities, what causes disparities. I'm going to spend most of the time talking about solutions. I do want to refer you, though, to this national resource, the AHRQ National Healthcare Disparities Report. It's published yearly by this part of the government that looks at quality of care and disparities. There's the website. But the basic message is that there's been some progress in some areas, some regression in some areas, but on the whole, we have a long way to go still towards removing healthcare disparities and achieving equity. So I'd like to segue into two different stories to start with. The first story, so I've been at the University of Chicago, as Lindsay mentioned, for a long time now, like 22 years. And maybe the first 16 or 17 years I was there, it was the same chief financial officer of the organization. And he would go to the departments each year and basically give, the state of the medical center's finances. And the point he made at each of these different talks each year was that, in the Chicago market, which still has a lot of fee-for-service payment, the Chicago market is a relatively small percentage of the patients who came to the University of Chicago who brought in the money that basically subsidizes the rest of the university's teaching, research, educational mission. At the University of Chicago, it's basically 5% of the patients. And who are these 5%? It's basically ordinary care patients. It's organ transplantation. It's like orthopedic surgery, GI procedures, chemotherapy. It's a relatively small percentage of the patients. So at one point, after I heard this talk 3 times in a row, I said to him, isn't it a little risky basing the university strategic plan on only 5% of the patients? Because the plan really was to increase the flow of those type of patients in the university. And what he said to me was essentially, Marshall, you smart aleck, someone's asking this question every year. And my answer is always the same. What has changed in the payment market or the way that we are funded that would make me change the strategic operation plan? And so I thought about it for a moment, and I basically had to be silent because at least at that time there really wasn't much happening. Well, about 5 or 6 years ago, we had a new dean and head of the medical center come in. This is Ken Polanski, who's a diabetologist, eminent bench scientist. And we started seeing things change pretty rapidly. That for the really first time seriously, there were sort of efforts in terms of population health and looking at the South Side of Chicago, which is primarily African American, and what can be done. And there was the start a couple of years ago of a major sort of health equity initiative, both in terms of cultural competency training and really trying to make care equitable across the university. And so why did this happen? Well, I think part of it is that Ken thought it was the right thing to do. That he has a very interesting background. That he grew up in South Africa, really at the height of the apartheid era. And he'll actually tell you these stories where, as a student at the university, participating in some of the demonstrations, and basically the secret police would film the demonstrators, so they have a record of, who was demonstrating. And some pretty scary stuff, and I'm sure scary stuff you saw in terms of the apartheid. But part of it was the right thing to do. But also, I'm also not naive enough to believe that that was the only reason why, Dean Polanski did this. The Chicago market is rapidly changing, and that the financial incentives are changing, that there's starting to be more and more global payment. So I understand that you have the major ACO here in Seattle. There's more bundled payment. A lot of the Medicare and Medicaid contracts are starting to be at risk, meaning sort of a fixed bundle of money that then, if you are efficient and you save money and you prevent illness and hospitalizations, well, you pocket the savings. Ergo, these more serious efforts of population health. Also, the community needs assessment for nonprofits, big thing, where to maintain your nonprofit status, which is worth millions of dollars to University of Chicago and I'm sure the University of Washington also, there need to be some type of assessment as well as a demonstration of benefit community. So starting to align. My second story is a shorter story where This project I'll tell you a little bit more about a little bit later in terms of diabetes care in the South Side of Chicago. For the clinics, we're working with our federally qualified health centers. And in full disclosure, I'm a fan of federally qualified health centers. I used to work at one in Chinatown in Boston, and I do a lot of work with them regionally and nationally. I think they are, on the whole, very mission-driven, very idealistic people, very creative folks. So this is Chicago Family Health Center, which is one of the centers participating in our project. And so, we do check-ins every so often. And so, like maybe about half a year ago, we checked in with the medical director about this overall project. We're doing a variety of things in partnership with them to try to reduce disparities. And what he told me was, well, yeah, we love, the general ideas of what you guys are doing, but to be honest, even here in our health center, and they have a very good health center, very motivated and very with it. There's only so much we can do because of the financial model, So these two stories, academic medical center, fairly qualified health center, two things are sort of happening simultaneously. One is sort of like, making equity a priority, it's the right thing to do, but there is this issue of, the nuts and bolts of the business case and the financing and, what can people do given the healthcare system. So we'll return to these themes over the course of the talk. So a lot of what I'm going to tell you about in terms of this roadmap to reduce disparities is based upon work from this Robert Johnson Foundation that Lindsay mentioned, this program we have had over the past 10 years called Finding Answers, Disparities Research for Change. We have an easy-to-remember website, solvingdisparities.org. And the program, we selected and monitored 33 grantees that have done interventions to reduce disparities. We perform a dozen systematic reviews of disparities intervention literature. And then we provide technical assistance to a whole variety of different sites that are trying to reduce disparities. So basically, we try to provide information about what works, what doesn't, and create practical tools to help people try to reduce disparities. National programs, so grantees from across the country. The technical assistance we provide to is also sort of nationwide, including a group in Puget Sound, actually a very good group. You guys are really at the forefront of a lot of quality work and disparities work nationwide, so you should be very proud of that. So we've learned a fair amount, I guess, through the School of Hard Knocks in terms of what works and what hasn't worked. And for those of you more interested in more details, in our website, we have a Journal Trimester article that summarizes this and goes into more detail. The interesting thing, too, I'll point out is that, so I've given variants of this talk to a lot of different organizations, medical organizations, insurers, the government, consumer groups, et cetera. And uniformly, people like it. And I think it's because it resonates with people's practical experience. It's a very practical sort of roadmap, and it jives with people's practical experience. There's the old joke about your 15 minutes of fame. This is literally your 15 seconds of fame that they flash, your picture and the logo 3 or 4 times over the course of a day for 15 seconds. But it's immortalized forever in the picture. Yeah. So here's the roadmap, and we'll go through each step in more detail. I just want to point out on this slide that I think in healthcare we have tended to fixate upon 2 of the steps. One is recognizing disparities, and the other is designing interventions. But the point is, if the goal is sustainable change, and really that's the goal, that if things aren't sustained, you really aren't going to have lasting change. Well, you got to address all 6 different steps. And again, we'll give you this sort of comprehensive look. So the first step is recognizing disparities and committing to reducing them. And here I'll talk about 2 different aspects. The first being examining your performance data, your clinical performance data, stratified by patient's race, ethnicity, language, socioeconomic status. So for those of you who've read through the full Affordable Care Act, which is a pretty tough slogging to read through, it's probably at least a half dozen times they mention this, collecting performance data, so basically how you guys are doing in terms of your quality, but stratifying so you compare how you do, for example, your white patients versus your African-American patients or your insured versus your uninsured. So what this does, people think, is that it increases people's willingness to change. So people have surveyed physicians, and they ask them, well, how many believe that healthcare disparities by race and ethnicity exist somewhere in the country? The answer is about 90% of physicians nationwide will say, yeah, somewhere in the country these disparities exist. The next question people ask is, well, in your own personal practice, how many of you think that disparities exist in the patients you personally take care of? And so if you think about it for a moment, then the answer is that it goes down rapidly. So it goes down from 90% to about 40%. And the reason is why is that, most physicians, probably like all of us here, that, we believe we are moral people. We would never purposely discriminate against patients. There aren't going to be disparities in our own practice. But by and large, when you look at the data, there's a lot of different practices and organizations where these disparities exist. But people have to see their own data. Otherwise, they're not going to believe that disparities exist, and they're not going to be motivated to think about how can we reduce disparities. The second aspect is basically cultural competency or disparities training. So I'm actually curious, like in this audience, how many people have had some type of disparities or cultural competency training at some point in their medical careers, either during training or after they finish training? So virtually everyone, I say it's probably 80% of people raise their hands there. I think now, for the people going through medical school now, I think almost every medical school has some type of aspect of this. So this is the Society of General Internal Medicine Goals for Health Disparities courses. And one of the problems is that a lot of these courses aren't really thorough. This is Wally Smith, or as we affectionately call him, Big Wally. He's a big guy, a great guy. And so he led this group at the Society of General Internal Medicine and came up with these different sort of goals. 4 goals being courses to cover the existence of disparities, the cause of disparities, solutions. So we'll talk about, we're doing some of this today. Courses generally address issues of mistrust between patient and provider, subconscious biases that we all have, stereotyping, how do you develop trust, how do you develop better communication skills, and then very importantly, how do you get people to commit to reducing disparities? You basically teach these things, but it doesn't necessarily translate to people actually believing and committing to reducing disparities. One of the themes of this talk is that leadership does matter, and the woman at the upper right her name is Monica Vella, who's at the University of Chicago, and it became her passion to create a course for the students. And so she's done it now for about 10 years, and it's now a required course. So the students at the University of Chicago, they take 2 courses in the fall. One is anatomy, and the other is this health disparities course. Being thought to be very important, very up front, so that students, are basically given the message that it's important. And so she does a variety of things that make the course innovative. There are self-insight exercises, like on the first day of class. Oftentimes there'll be an exercise where you think about what's the first word that comes to your mind when you hear the word doctor. What's the first word that comes into your mind when you hear the word welfare recipient? So it's an entree into talking about sort of subconscious biases. Field trips. So early on, then the students are taken to the neighborhoods where our patients tend to come from the south side of Chicago, so they get a sense of where do people live. One of the best read sessions each year is a little bit on Chicago history, where they take a non-health example, segregation of housing in the city of Chicago, which is pretty common in most cities. Probably, I would imagine, it's an issue in Seattle also. And so you learn, as a sociologist gives this talk, and you learn that it's not just by chance that segregation is segregated housing. There's basically a series of conscious decisions by the city council and policymakers and the building developers that led to this segregated housing beyond the free market. There's a group disparities project, so students in groups of like 8 or so will work on an actual disparities reduction project. There's reflective essays. The course covers everything from individual patient care, like how to work with interpreters, to macro policy, like Medicare policy. And I think actually one of the insights that Monica had and the course had is that over the past 2 years, advocacy has now become a bigger part of the course. In fact, like the subtitle for the course includes advocacy. And what Monica and Val Press, the other co-leader, learned was that without the advocacy piece, students felt sort of disempowered. That if you hear a lot about, disparities exist, a lot about cause of disparities, but, how do you get involved and how do you reduce disparities? If there wasn't that part, people actually, got disillusioned. And so there's been a lot now built in the course about how to be an advocate. And for people, in some ways, to find where along the spectrum of advocacy do they feel comfortable. Some people, they want to march in Washington and, do active advocacy work there. Others, individual advocacy for the patient. And a lot of people, it's like, what do we advocate within a health organization like the University of Washington or University of Chicago? Does it work? This road step number 1 in terms of data and cultural competency. While the sobering data is that these disparity data interventions, like feeding people back their own data, they're helpful for improving awareness, but not sufficient to remove clinical numbers like blood pressure control or A1C control in a diabetic patient. Similarly, the cultural competency interventions, they improve knowledge and attitudes, but again, they're not enough to move the clinical outcomes that we're familiar with. So basically, you have to pair those with other interventions we'll talk about, but they are important to basically stay on the stage. In some ways, it's not surprising because, so what people tell us that we provide technical assistance for is that, they show us the data, it shows us the problem, but the data don't really tell you how to solve it, what the solution is. So you basically have to sort of do both. So many of you are probably starting to follow the presidential election as the Republicans have their debates. Has anyone seen this particular picture before? A few heads nodding. So I had this aha moment maybe about 3 weeks ago. So what this is Hillary Clinton, and then you're all probably familiar with the Black Lives Matter movement. This is the one where there's been, with the violence against African Americans, the police violence, there's been a group, ethnic group called Black Lives Matter who been basically trying to raise awareness. So they actually disrupted a couple of the other Democratic candidate talks. So you may have heard that Martin O'Malley, who's the governor of Maryland, and then Bernie Sanders, the guy from Vermont, actually sort of disrupted, and they actually had to leave the stage. So Hillary's group, they actually made sure that security didn't have this group interrupt her candidate's speech. But Hillary did agree to speak after her talk backstage to the group. So if you do YouTube, you'll find actually this 10-minute video where it's fascinating that for about 4 or 5 minutes, the man on the right is basically talking and trying to get Hillary Clinton to acknowledge some guilt for when President Bill Clinton was president, the changes in the drug laws that led to more incarceration of African Americans. So Hillary listens very carefully for like 4 minutes, nodding her head, very patiently. And then she sort of lets loose. And, so like one of the criticisms of Hillary Clinton candidate is that she has been very cautious. Not in this video, where she basically pushes back. And here are a couple quotes. This is from the New York Times from August 19th. You can get lip service from as many white people you can pack in Yankee Stadium, and a million more like it who are going to say, we get it, we're going to be nicer, she says. That's not enough, at least in my book. Later on, she says, and the article goes on to say, I don't believe you changed hearts, Mrs. Clinton says, summarizing her basic view of social policy movements. I believe you changed laws, you changed allocation of resources, you changed the way systems operate. So, Senator Clinton is talking about the Black Lives Matter movement here, but in some ways what she's saying I think we can apply to healthcare disparities and equity. I think there's something she gets wrong here and something she gets right. What I think she gets wrong here is that I believe that you do need to change hearts. People have to believe this is important. That if people don't believe it's important, they're not going to be passionate about it, not going to work on it. But at the same time, what I think she does get right is that you just can't tell people that achieving equity is an important thing, or cultural competency is important. That you do need to do some of the systems things, the laws, the resources, the way systems operate. And we'll go into this now. So real step 2 is implementing a basic quality improvement structure and process. And so again, this issue about if you don't want to be just sort of a standalone thing that, you do your disparities intervention and then it goes away, you've got to embed the quality improvement. So having a culture of quality, a quality improvement team, you set goals, you measure those goals, you have the local champion, you have support of senior leadership. So related to that, there's something which I think nationally we don't do a very good job is making equity an integral component of quality improvement efforts. So some of you have heard familiar with these IOM reports. The one on the left is unequal treatment, which is the equity report. The one on the right is crossing the quality chasm, which show that there's a quality problem in here. And then in between you represented, the Grand Canyon, that this is a gap. And at too many places, the people who work on quality are different from the people who work on equity. Now, you guys are lucky at the University of Washington. I mentioned you guys are at the forefront, and Seattle's the forefront of these efforts. And here locally, you have people like, Tom Steiger or D.C. Dugdale or Tom Gallagher, or at the VA you have Steve Finn. These people are that work in quality, and they get the equity part also. So it is, more so at the University of Washington than a lot of places, integrated. But what does this mean in practice? So each year, this picture or a very similar picture shows up on the University of Chicago website, which is the University of Chicago employees marching in the Bud Billiken Parade. Does anyone here know who Bud Billiken is? So usually in a group of this size, there'd be 1 or 2 people that raise their hand who both are from the University of Chicago. One person will take a guess and they'll be wrong, and the other person will take a guess and they'll be half right. So sort of a trick question. A Bud Billiken is a fictional character there's a very famous African-American newspaper in Chicago called the Chicago Defender, which back in the 30s and 40s, they created this fictional character, Bud Billiken, who was basically designed to show little boys and girls, what it is to be a good person. So it became a role model. But there's this big parade. It's the largest African-American central parade in the United States that occurs once a year in Chicago. And so, the African-Americans, employees and the other employees in the University of Chicago marching in the parade. The point is that, it's not to denigrate community events that, probably a lot of people here have participated in a community volunteer event at one point or another, and it's a great thing to get our kids involved in at an early stage. But if that was all the University of Chicago did to work on equity, basically marching once a year in the Bud Billiken Parade, well, that'd be, a drop in the bucket, as opposed to, if in every quality improvement effort we do, whether it's asthma, whether it's prenatal care, whether it's an HIV intervention, we think about, how do we provide the best possible care wherever our patient is and making sure the barriers that patient has are overcome. So the quality people here, most people have heard of the IOM 6 pillars of quality. How many people have seen this exact slide before? This is fairly typical, that even in an experienced group of clinicians who do quality work, there's usually like maybe 2 people in the audience of slides that will raise their hand. But people don't often realize that in 2010, the IOM actually revised their model of quality. So you see, for example, equity, which used to be one of the 6 pillars of quality, has been taken out and becomes a cross-cutting dimension-like value. Thought to be so important. You think about equity and all the other pillars. So effective care, safe care, timely care, patient-centered care, efficient care, accessible care. You think about how equity can be embedded in all those different things. So it really is a fundamental philosophical shift in how we think about quality of care. So the 4th roadmap step is actually design and intervention. I'm going to talk about 2 different aspects, determining root causes and then 6 levels of influence. So the root causes is common sense. So, if there's a problem like, the rates at which diabetic patients are having their feet examined are separate between, insured, uninsured folks, you basically, do your QI root cause mapping and try and figure out, why is that the case? And then depending on what the why is, then your solution addresses those whys. What I want to make here is that there is no substitute to talking with the target population. So, for example, if you are looking to help your African-American patients, talking to your African-American doctors and nurses is no substitute for talking to your African-American nurses, patients with diabetes. Give an example. One of our grantees was a neighborhood health plan, a Medicaid health plan in Rhode Island. And they looked at the data and they said, our Latino patients with depression were doing worse than their white patients with depression. And so they brought together the Latino doctors and nurses and said, what should we do? And they thought, the solution was a telephone intervention because, you get through like the transportation barriers because you phone people, you can do broader outreach. People sometimes are fearful going to the doctor. So they thought this was going to be a solution that would work well. So a very well-intentioned group. They started the intervention. They had trouble enrolling more than a dozen people. So it turns out there were 2 main reasons, in retrospect, why it didn't work. And my guess is, for example, if they had done like a focus group of a couple dozen people or, talked to a half dozen people, they would have found what these are. One was that it was the cost of the cell phones. And it's an issue, not people didn't have cell phones. Most people did have cell phones. But most of the plans people had were the pay-by-the-minute plans as opposed to the unlimited minutes. So people couldn't use their cell phone minutes for this. The second was one which, the doctors and nurses, Latino doctors and nurses just wouldn't be aware of, which is right around the time the governor of the state was starting to crack down on the undocumented workers. And so this was a big thing, in the undocumented community. But again, in the socioeconomic circles that the Latino doctors and nurses travel in, wasn't talked about. So that's always been a very vivid example for us in the program. So here's our conceptual model for thinking about interventions. A sort of common sense model. If you're a person, you live in the community. If you have access to care, you become a patient, interacting with you, the doctor or nurse, in the healthcare organization. Above that, you have a policy superstructure. The big hammer is financing. So, for example, above Medicare and Medicaid and then private financing. Increasingly, regulation and accreditation. So the Joint Commission, for example, is working on some equity issues. Ultimately, these improve the process of care and outcomes. So basically, these provide your targets for improving care. So I'm going to use pediatric asthma as an example, and just give you an example like research questions or type of interventions you might do at the different levels. For example, policy. How can you change policy and resource allocation to promote clean air, reduce exposure to secondhand smoke, and a non-allergenic housing environment for kids? The health organization, how can ED visits and readmissions be reduced by enhanced primary care access by doing things like extended hours? The microsystem is the immediate care team. So, for example, can you embed community health workers with your doctor and nurse teams to support home-based asthma management? For providers, so, for example, and I heard, for example, that in some of your primary care programs, you have a really neat sequence on motivational interviewing. So can you train providers in culturally appropriate motivational interviewing to promote self-management? Can parents safely use email or text messaging to receive real-time advice on handling severe asthma exacerbations? In the community, can you use school-based programs to screen student athletes for asthma? Those are some examples. So, when you look at the data, and so we did these 12 evidence-based reviews of about 400 existing disparities intervention articles in the literature. There's not a lot of common themes about what works for reducing disparities. And, here's the best we could do. First, multifactorial interventions that attack the different levers that cause disparities. Culturally tailored approaches are better than generic quality improvement approaches. Team-based care. There's a lot of good evidence, particularly for nurse-led care. When you think about why that may be so. Surprisingly, involving families and community partners. Use of patient navigators, community health workers, lay health workers. And then interactive skills-based training. So, for example, having the patient demonstrate and try out how to use an inhaler as opposed to didactically lecturing them on this. So what it means in practice then is that there's no substitute for the hard work of QI. You basically have to find out what's relevant in your particular patient population and then tailor your intervention for those barriers. So in other words, what I learned in Chicago may be helpful for what works in Seattle, but you probably have to tailor. Similarly, I can learn from you in Seattle, but I'm going to probably have to sort of still figure out how do I tailor for my particular population in Chicago. So again, there's no magic bullet. So implementation, so the VA folks here, they may recognize Laura Damstruder, who's an investigator at the Ann Arbor VA in Michigan. She has this consolidated framework for implementation science research, sort of one of the new emerging areas. But the point being that when you think about either research in this area or else actual, ground roots implementation, you got to think about a variety of factors that would make someone more or less likely to basically adopt your program. So what is the relative advantage of your intervention as opposed to the status quo? What are the external incentives the system has for doing what you're suggesting or not? What's the culture of your organization? So probably, for example, I would bet that the culture at Harborview is different than the culture at the medical center here versus the culture at the VA to some extent, even though it's the same house staff. What are the beliefs of the individuals, the folks, the places? What's the process for planning, executing, and then evaluating your intervention? And so I like this slide. This is sort of like, I like it because it's sort of behavior change theory in one slide. So, the people in this area, will laugh at me trying to put on one slide, but I do think that it does capture most of the different things. When you think about any type of behavior change, which is, quality improvement or teaching, for example, it's all behavior change. The same with the equity and disparities reduction. So first we're taught that, well, if you only teach people, if you only taught the patient about, why you should be, taking your medications, if they have the appropriate beliefs and knowledge, well, then they'll change. Then we have to rapidly realize that that's helpful, but it's not enough. That's not the way the world works. So then we think, well, okay, people are part of organizations. So there's social norms. So for example, if you're a house staff officer here, there's the culture, of your house staff program. And so when you think about, well, what are the social norms that we build in a given program? That's part of it. Well, then there are environmental factors like incentives, like financial incentives. And then very importantly, self-efficacy, the jargon word for confidence. So in other words, you could know what to do, but if you don't have the confidence to do that, well, you're going to be less likely to do it. So for example, if you're an intern, you hope you have that wonderful resident who gives you the guidance and stuff, but also gives you enough sort of autonomy so that you can develop the confidence, basically shine, and develop, your abilities then as a physician. They're all important. And then there's motivation. So this is one of the current forefront areas, and people sort of think about motivation both in terms of two different types. There's intrinsic motivation, what comes from within, your professionalism, your sense of doing the right thing. Then there's extrinsic motivation, like finances, and pay for reforms, for example. What people think right now is probably both are important. So one thing is that there's only so many things you can incentivize. So ultimately, people have to be doing it for the right reasons because, there's just so many things that are inherent in being a good physician or trying to reduce disparities. It has to be done because people believe it's the right thing. But then there probably is a role for financial incentives and other motivators. So the final step is sustainability. And so, how do you institutionalize things, make things part of the basically standard operating procedure? So you may have heard like these numbers, the societal cost of disparities. And there's a lot of direct and indirect costs. The argument you'll hear is the healthy workforce issue argument, where by 2050 we'll be a majority non-white population. So if we're going to be able to compete globally in the marketplace, we need to have a healthy workforce. But the other perspective is the business case, which takes me back to those original two stories I told you. Now, where's the business case? It's just a reminder, the things we went over earlier, that it is evolving and it is becoming more powerful, the business case, but more needs to be done to build up the business case. Lindsay mentioned that we are starting another program here, which actually folks at the School of Public here at UW are one of our grantees, where we're looking at how do you basically combine delivery system intervention reform, so systems interventions, with different types of payment reforms, such as pay performance, global payment systems, shared savings programs, to try to reduce disparities. I'll come back a little bit later. So I'm now going to go macro and just give you a couple examples now, we're doing here in the South Side of Chicago, which I know here, like both with public health as well as medical health here in Seattle, you guys have been one of the forefront regions also. I want to point out especially the woman on the far left. Her name is Monica Peak, who's co-PI with us on me, and she's been a tremendous leader in this particular field. Some of our wider team. So one statistic slide. So the south side of Chicago, where University of Chicago is and where I live, you walk around and literally 1 out of every 5 people have diabetes, whether it's diagnosed or undiagnosed. And if you live in one of the predominantly African neighborhoods of the city of Chicago, you have 2 to 5 times the risk of having your leg amputated than if you have diabetes and you live in one of the predominantly white neighborhoods. I think we're all familiar with sort of the challenges of the inner city, poverty, food deserts, violence. But oftentimes people overlook the great strengths of the community resources in places like Seattle or Chicago. We've had a lot of bad press recently in Chicago about violence and the gun shootings. But again, a lot of good things happening here in the city, and there's a lot of resilience in the people of Chicago. We also have sort of an interesting mayor who is like one of these larger-than-life characters, Rahm Emanuel. And interestingly, health has actually been one of his major interests. And so he's been doing a lot of things, for example, putting in like some of these states have been putting in like bikes that people can basically rent and go from station to station, and a lot of sort of healthy living type things. This was the most recent commissioner, Bashar Shakir, and so Monica Peak and I, we recently had a blog post in Huffington Post talking about populational things that people can do, both collaborating with the Department of Public Health to try to reduce disparities. Then our story, so I'll point out in particular Michelle Obama. So the guy above that is the president of the university, Robert Zimmer, who made health one of the 2 community priorities. And then somebody made the story that right before she went to Washington, Michelle Obama's prior job was one of the VPs at the University of Chicago. And so she was instrumental in forming this urban health initiative, which was the start for some of these efforts to reduce the disparities on the south side. Just one aside that, so I've met her twice in person, like in small groups. And she's actually, I think, more impressive in person than what you see on TV. I think in some ways may have been restraining her public persona for whatever reasons, but she's very impressive in person. And their children went to the same school that a lot of the University of Chicago faculty send their kids to. It's like this private school called the University of Chicago Lab School that's affiliated with the university. But there was like this annual fundraiser that occurs. And so like when Barack Obama entered the fundraiser, he's sort of like any other dad. He basically wanders over like the art exhibits of the kids and pretty ordinary guy. When Michelle Obama entered the room, she just lights up the place. This is charisma and says, whoa. So she is an impressive person. Health Affairs article that goes into some more detail for those interested. I want to focus really upon the community partnership piece. I believe enough time for questions and answers. I'll go through some of the other parts of the project, but particularly community partnership is part I want to focus on. The quality improvement part, we're working with 6 different clinics, including the 4 FQHCs. We're doing some provider training in cultural competency and motivational interviewing. One of the most innovative parts of the project is this culturally tailored diabetes education part. And, one of the parts that Monica's led, and one of the parts I like about it is that you hear this word cultural tailoring a lot, but you hear, well, what does that mean, cultural tailoring? So here's one example. What Monica did was she did it the right way. She started with qualitative work, basically talking to patients about, what would work for them in a program. So one example is that, one thing that Monica's taught me about is that, so a lot of the African-American communities, the faith-based communities, are a very important sort of social network for a lot of historical reasons. But there's this tradition of storytelling in the African-American community. And you think about it, slavery era, oral history became important as the way that people would be able to pass down the traditions. And so often, also in the African-American church, there is this history of basically telling your story or testifying before your peers. And so she embedded this in these diabetes group lessons where multiple times people have the opportunity to basically tell their story, testify in front of their peers about, for example, the barriers they're having facing improving their diabetes outcomes, or things that have worked for them. That's been built in from the beginning. Programs shown to reduce A1C. Another example is that Shantanu Nundi, who was one of our fellows, he developed this text messaging program as a way to start to bridge the gap between what happens in the community and what happens in the healthcare system among our HMO patients. And it was sort of like the holy grail where it improved A1C and then also saved the health system 9% on the diabetic patients overall. Community partnership, and I'll talk about this in a little more detail. So this is the part of the project that has expanded in ways that we just never would have guessed would happen. But I think it's pretty powerful because, as you know, some of the social determinants of disparities are the community determinants, and so we have to start working on that angle also. We do a lot of public education and media work, and so this is one of our former endocrinologists, Suma, who's showing a popular cable TV host in the African American community, Jacinda, how to check your blood sugars. We do a lot of work with radio, so VON is one of the African American radio stations in the South Side. So we do a lot of health education, a lot of radio spots. And one of the things I want to point out about this is that you don't have to be some expert to basically do this. That, the things that the community want to hear are really the basics. And so the person on the far left, she's a vascular surgery fellow. First time she ever done this, did a great job in terms of basic food education. People loved it. We do a lot of work with healthy eating and exercise in the community, both with nonprofits and for-profits. So, for example, Save a Lot is the low-cost jeweler, grocer in the Jewel-Osco chain. So this is Marley, one of the diabetes educators, showing how to read a food label, not in the classroom, but in the grocery store, where many of our patients will shop. We have this food prescription program, so a way to get people to a little bit discounts on the coupons, but then also it drives people towards the healthy options. Walgreens has started putting some of their in the food desert pharmacies, healthy food options, and then we do work with the food depository, the food pantry in Chicago, and then some of the farmers markets. Shows you an example where the farmers markets, they have great food. We have tours so that people will introduce people to farmers. We have cooking demonstrations for the healthy food. This is one of the aldermen who's getting involved. This is one of the social service organizations that we participate. They have like a monthly food pantry event, which again you see the food is really good food, but we've helped transform it from a food pantry event into a health event. So, for example, there's Monica. She's about to give a food educational talk on diabetes or hypertension. These are cooking students from the local Kennedy King Culinary Community College who are basically showing some ethically tailored recipes for the food be given out at that event. Some one of our medical students doing some glucose screening. Nursing students doing blood pressure screening. The students love it in terms of really exposure to patients. And then we try to combine it. So for the man in the orange, the one on the right, they're patients from the diabetes class who are at this food pantry event. So trying to make it seamless what happens in the community with what we do in the healthcare system. And then we do this awareness events. So it's a diabetes cook-off, so it's a fun event where people try to have create healthy recipes for diabetes patients. In one example, we partner with them with our media relations and our marketing people at the university. So you see in the background, that event. I put this on the slide. For those of you who know Chicago, or those of you who've flown to Midway Airport, if you then go directly east from Midway Airport, you then start, you encounter this billboard, but also this is like a stone's throw away from one of the two sites that have been considered for the Obama Presidential Library. Interesting for you guys. The sign. So in this part of the talk, our thoughts are, well, take action, do something, be inclusive. We never would have guessed, for example, that we'd be collaborating with Walgreens on food deserts on the south side, or the farmers markets and the food pantries. Gain skills and work with the media and public relations. Understand historical, policy, economic context. We can talk a little bit more about that later. Don't be afraid to create an action-oriented, integrated healthcare community project. So I'm going to go micro now, and one of our most recent projects, talking to the chiefs last night, that has given us some of the most aha moments is this new project where we're looking at how do you improve shared decision making between clinicians and LGBTQ racial ethnic minority patients. And in some ways, this is one population, but I think the lessons really are transferable more broadly. So for this particular talk, I just want to talk about a couple of conceptual models we've been developing based upon this work. So all of us, no matter who we are, we have multiple identities, based upon our ethnic background, where our gender, our socioeconomic status. And so we have a perception of ourselves. Part of that perception is a reflection of the values society has had on different things. So, for example, the way society views men and women, to some extent will color than how we as individuals view ourselves, whether consciously or subconsciously. Similarly, when you think about this, you as a clinician talking to your patient, we view them through a certain lens based upon their superficial characteristics. Similarly, they view us through a certain lens based upon our superficial characteristics, at least initially when we see them. And then we all have these implicit biases and prejudices. It's not just us, though, this dyad. It's society, too, has certain impressions of, us as clinicians or, our patients, and that sort of impacts us also. It gets you down to this diagram where, the classic, in the middle you have the classic shared decision-making triad. You share information, you deliberate about pros and cons, you eventually make a decision about what to do. Hopefully, if it's a good process, you have, better trust, satisfaction, understanding. For the clinician, hopefully it leads to better job satisfaction, better patient-centered care. For patients, you hope it leads to better adherence to medications, better self-management at home, better outcomes. And, embedded in this are preferences and then the trust that hopefully exists between patient and provider. But above that, you have then, all this unspoken stuff. So we talked about, internally ourselves, our own self-perceptions, and then again, all these things going on in our heads. That we're saying one thing back and forth with patients. They're saying certain things to us, but there's all this stuff going on in our head about, how we're sizing each other up also. So, for example, for the LGBT community, there's this issue of disclosure that, unless you have that trust, with your provider, you're not going to disclose, sexual orientation, gender identity, and so that, unless a safe environment is created, you're not even going to get to some issues of shared decision making. This has just blown up in social media over the past couple of days, but some of the folks who've been on call and stuff may not have seen this. Are people familiar? How many people here are familiar with this picture? Yeah, it's amazing, social media. So this is Ahmed Mohammed. So for the folks who haven't seen it, he's a 14-year-old kid in Irving, Texas, which is, I guess, in the Dallas-Fort Worth area. And so he's like this prodigy who, since age 8 or 9, has loved to fiddle around with his hands in terms of creating engineering projects. So I think it was Monday, he brought into school a alarm clock, which he had created, basically wiring together to like a digital display, some wires, and a battery. And so he wanted to basically impress his teachers, and he was very proud of it. He showed it to one teacher, a computer science teacher, who said, "Great, don't show it to anyone else." In his English class, the alarm went off, and so the class stopped, and he had to show it to his English teacher. One thing led to another, but eventually a couple of policemen then brought him to the principal's office, and then I think 5 policemen interrogated him, asked, "What is this?" "It's an alarm clock." "What do you mean it's an alarm clock?" "Well, it's an alarm clock." And they brought him to the police station because he wasn't more forthcoming in terms of explaining what it was, but, it was an alarm clock, so what else could he say? He was handcuffed, and for an hour and a half, they wouldn't let him see his parents. And I guess the story was like, I heard an interview where when he first went into the 5 policemen, the first thing one of the policeman officers said was, he said the policeman reclined in his chair and said, "I knew it was going to be someone like you." So anyway, it's a pretty horrendous story, but I think part of it is what we've just been talking about in terms of like the subconscious biases people have, the impressions people have. And part of it too is the culture created. So like evidently the mayor of Irving, there's been concerns about some Islamophobic statements she has made, which probably helps set the stage for this. So a lot goes on both internally as well as in like the cultures and areas that we're working. Just to point out, there are things in the organizational context, like the way we organize our clinic, that can make things more or less conducive to shared decision-making. So, for example, if there's private space, for example, or the artwork you have on the walls, if it establishes a safe environment for, an LGBTQ or racial ethnic minority population, for example. So I will end with this, that at the end of 2014, I was invited to write editorial on a couple articles that are coming out in the New England Journal of Medicine on disparities. One article basically showed that processes of care in hospitals are improving for all populations, but actual outcomes, like in the outpatient setting in particular, weren't improving. So I knew this was going to be sort of an important opportunity because there's a chance to basically have a wide viewership, and especially for a lay audience. So I thought hard about this, about what would I condense into like 750 words of the key lessons, and basically how would I condense this talk to a lay audience in 750 words. So this is what I came up with. Basically, 4 different points. You got to look at your own data. That again, because people just won't be convinced that they do work in their own area because they don't believe the disparities as they see it. These interventions, they all devolve down to basically talking to your patients, right, and then tailoring the care to meet the needs that they have. It's as simple as that. This third part of the policy point about aligning the incentives. And one thing we haven't talked about really is assisting the safety net, but because we still have our current U.S. healthcare system, which still is flawed despite the Affordable Care Act. We still have to do things for the Harvard Reviews of the world, otherwise they're not going to survive. So last Tuesday, I was at CMS, which is the part of the government that runs Medicare and Medicaid. They're having a celebration of this 30th anniversary of this first report looking at disparities on black and minority health. And actually, Secretary Heckler was there. She was 85 years old at the time. Pretty frail, but doing pretty well, really sharp still. And so I was pretty direct and honest with them. I told them basically that, you're doing some great things, but frankly, you still aren't doing enough. And I told them, here's what I said to them, that, low-hanging fruit, require public reporting of stratified disparities data. And actually, they were about to do this, so it's coming down the pike very soon. You got to have more incentives for prevention and primary care. That, right now, it's too many incentives basically reward the University of the world for basically, taking care of the complications. You got to reward the primary care, the prevention, keeping people out of the hospital. You got to explicitly incentivize reducing disparities. That, I like a lot of things about the free market, but to believe that the free market is going to magically lead to reduction of disparities ain't going to get there, probably. So I think you basically need to specifically incentivize reducing disparities, doing things like rewarding relative improvement disparities, absolute performance levels, thinking about what are the appropriate comparison groups. If you compare a UW, who's your appropriate comparison group, for example. The safety net, adequate payment, support for quality improvement in institutions, risk adjusting, so you're not, penalizing Harvard Review for caring for a particularly challenging population. Specifically building equity accountability measures into payment programs. And then what this really means is that you do blended payment approaches. So blended meaning, a combination of, pay for performance as well as some global payment methods, and quality improvement, and both having a specific goal of reducing equity, reducing disparities, improving equity. And, I end this editorial by saying leadership matters. It is our professional responsibility as clinicians, administrators, and policymakers to improve the way we deliver care to diverse patients. We can do better. So what can you do to achieve health equity? So, three things. One is increasing the readiness and motivation of frontline organizations, clinicians to reduce disparities. So when you're attending on the wards or you're the resident on the team, making a point to show the students, this is important, equity. Providing skills to reduce disparities, whether it's quality improvement skills, whether it's some of these cultural competency skills. And then aligning incentives. We talked about Medicare, what they can do. But, one thing I learned from Dean Polanski's example was that, it makes a difference when, senior leadership says, well, this is important. And, Dean Polanski is not necessarily an expert in equity, right? But, he made it a priority and he put people in charge that, have more, the expertise to do it. And it's been making a difference. So, aligning incentives to reduce disparities. So that's it there. So thank you very much.